kind of one of the key parts about why they are helpful diagnostically is the predictable part. They're helpful diagnostically because if they don't give us the predicted response or the expected response, that may indicate that there's some kind of damage along the reflex pathway. And that's why it's important for those of you thinking about clinical medicine in the future as a healthcare person to know a few examples of some of these pathways. And that's all we're going to introduce you to here at this point. And that way you'll have a good foundation at the next level to understand not just the ones that we'll talk about in A&P, but more that you'll learn about and how you can use them to test reflexes in your patients or clients. So here's how we classify them. These are the bold terms on towards the bottom of 71. And one of the first pairs of terms is whether or not a reflex is autonomic or somatic. And kind of the basic difference between the two is somatic are more voluntary muscle. What kind of muscle is the only muscle that's voluntary muscle? Yeah, skeletal muscle. So somatic reflexes usually involve moving some kind of voluntary skeletal muscle. Autonomic reflexes typically involve moving the other two kinds of muscle. What are the other two types of muscle? Skeletal is one. And what are the other two? Autonomic targets either cardiac muscle, muscle, or smooth muscle. Okay, the two that are not voluntary. Okay, so the one that I've got pictured here in the upper right, where if we use a reflex hammer to tap on the patellar tendon, it stretches the stretch receptors in the muscles on the front of the thigh and causes a reflex through the spinal cord, a reflex arc through the spinal cord, causing that same muscle to contract. But that muscle, even though the reflex itself is not voluntary, the target organ, known as the effector organ, is a skeletal muscle. This would be classified as a somatic reflex. This one down here is as well. This one's also somatic, because pulling your hand away from a painful stimulus is something that really begins reflexively, automatically, but it still uses skeletal muscle. The autonomic reflex, a great example, a kind of an easy example of an autonomic reflex that happens all the time, is when you go from inside to outside on a bright day and your pupils constrict in your eyes. Those are controlled by smooth muscle in the part of your eye called the iris, which is the pigmented part of your eye. It's brown or green or blue. And embedded within that are smooth muscles that can constrict that little hole in the middle called your pupil and reduce how much light gets into the eye. And that's an autonomic reflex. You are not at all in control of it, and you're not in control of those muscles under normal circumstances. You don't adjust the shape of your pupil. All right. Another good example is when you go exercise. If you go for some exercise, your heart will start to beat faster. You are not really directly in control of the heart on any normal, every ordinary day. It is an involuntary muscle, and making it beat faster is part of an autonomic reflex pattern. Okay, so that's one of the big categories, differences between autonomic and somatic. I hope giving a bunch of examples helps. Another way of classifying them is, I'm going to clear all this out of the way so we can see our drawings because I've got two examples here, is the reflex pathway, does it consist of one synapse or many synapses? So take a look at this one over here in the upper right. We've got one sensory receptor. This sensory receptor, its axon, goes through the dorsal root. There's its soma in the dorsal root ganglion, comes through the dorsal root and synapses with a motor neuron that sends an impulse out to the muscle fibers, causing the muscle to contract. All right? But there's only one set of synapses. There are two neurons, a sensory neuron and a motor neuron, and one set of synapses between the two. But if we look at this pathway down here, where you get burned, it actually comes from the surface of the skin, not from muscle deep below. And that pain still goes in through the dorsal root. There's its soma in the dorsal root ganglion. And it synapses with another neuron here in the gray matter of the spinal cord that kind of sends information a lot of different directions. One of those is that second one, pictured in white here, will synapse with a third neuron to cause contraction of the muscles on the front of the arm. But another neuron needs to stay turned off. So that muscle needs to get inhibited so that we can get the arm moving in only one direction. They don't both contract at the same time, straightening and stiffening your arm. It allows us to bend the arm and move it out of the way. So this involves many different synapses. There's one there, then there's one here, and one there, and one there, and even sending impulses up to the brain to let the brain know what's happened. You know, this one up here at the top is a basic tendon reflex that's mostly for balance when you're standing up. This reflex mostly works when you're standing, and it makes sure that you're able to maintain your balance and you don't sway forward and backward too much while you're standing. All right? Your brain doesn't need to worry about that. But if you get burned on a hot pot, your brain needs to know. The brain needs to know that you got burned. You need to pay attention to it. You need to repair the damage. You know, maybe go to the doctor if it got hurt really bad. Can everybody hear me? If you can't hear, yeah. So, yeah. Yeah, do your browser. Redo your browser. Yeah, if you can't hear me and I'm waving this little thing around and drawing all over it, that's your fault, not me. I'll do the best I can, but that's not on me. The other way of categorizing reflexes, the other way of categorizing them is as to the side. Now, we know what the word contralateral means. It means it controls the other side of the body. There aren't many of them. We'll talk about one example. But most of them are on the same side, and the word for that is ipsilateral, same side. There even are some examples of those that work on both sides. So the stimulus might be on one arm or leg or something, but it may cause reflex contraction on both sides. So these are just the words that we'll use as we talk about them. The basic parts of the mechanism that involve the reflex arc, you got to have some kind of a stimulus, 5 basic parts. You got to have a stimulus, got to have a receptor, which is a neuron that turns that stimulus into an action potential and sends that action potential afferently toward the spinal cord. All right, so you've got some stimulus, and then you've got a receptor that turns the stimulus into an action potential. Then, not always, but sometimes you have an interneuron, but always you have some sort of happening in the central nervous system, in this case, right in the spinal cord. There may be a second neuron here called an interneuron, but there doesn't have to be. As I showed you in the previous slide, it could just be that you have the sensory neuron comes in and synapses directly. Get my kind of thing straightened up here. Synapses directly with the motor neuron, but that still considered information processing. Kind of try to do it the same as this one. All right. Because that synapse between the two is still considered information processing. It still counts as info processing. Okay. So there may be an interneuron, there may not be, but the third part of the reflex arc is still information processing in between. That motor neuron is the fourth part. Activation of a motor neuron to send an impulse out to an effector organ. And that is where the difference between autonomic and somatic comes in. If the effector, a reflex is somatic, if the effector is skeletal muscle, it is considered an autonomic reflex if the effector is cardiac or smooth muscle. Okay. So, as we look at these, we just got a handful of specific reflexes. As we look at the first ones we look at will be somatic reflexes. So you'll see that the target organ, the effector organ, is skeletal muscle. The first one is probably one of the most well-known ones, called the stretch reflex. And it's called that because it's a response to muscle stretching. It's a response to muscle stretching. And deep in certain muscles, especially muscles in your legs and arms, there are spiral shaped, they're hard to describe, maybe because I don't understand them very well either. But deep within the muscle, there are these kind of spiral shaped neurons that are sort of springy like that maybe. And if you stretch them, they kind of spring out and get kind of tense like that. And when they spring out like that, that sends an action potential back to the spinal cord that says the muscle is stretching. And if that's intentional, then the spinal cord doesn't do anything about it. But if the spinal cord does not recognize that stretching signal, it'll try to compensate for it because the spinal cord is afraid that you're falling down, that the stretching is caused by your legs, your joints bending in an uncontrolled way. And it'll try to compensate for that by sending a contraction response to the muscle that was, the very same muscle that was stretching. So stretching is the stimulus, specifically stretching of the muscle spindle. So that muscle spindle detects stretch. And these would be mostly the large muscles of the hips and thighs. Muscles in the calves have them. But you actually have them in a few muscles in your arm, in the upper arm, what you'd call your upper arm. Okay? Now the patellar stretch reflex is a specific one. The patellar stretch reflex is one that involves stretching the patellar tendon and contraction of the quadriceps muscles on the front of the thigh. So at the top of page 173, it's asking what nerve would that be? Well, we just talked about it. Yeah, you may not have had time to review it or study it yet, but what nerve innervates the muscles on the anterior thigh, on the front of the thigh? What nerve? Yep, the femoral nerve. So the answer to that one is femoral. That's because the effector of this one is basically what we call the quadriceps muscles, or sometimes we just call them the quads for short, those muscles on the front of your thigh. That would be the femoral. Down in your lower leg, kind of right back here, we can do the same thing. What are these muscles on the back of your calf called? What are the big calf muscles called? I should tell you. Crazy long spelling of this crazy muscles, these crazy muscles. Gastrocnemius, yeah. The sural muscles, yeah, the sural muscles. Gastrocnemius and soleus are the major ones. And they all merge together into this biggest, thickest tendon of the body. I know. I'm trying to go kind of slow. I want to make sure we get through all of this, but do it in a way that everybody's able to process this info. So what is this tendon that's the biggest, thickest tendon in your body at the back of your heel? Oh, it's right here. There it is, the Achilles tendon. So you can actually use your reflex hammer. I'll kind of draw a reflex hammer here. Oh, that's awful. There's your reflex hammer, and it hits the Achilles tendon, and you can feel the gastrocnemius muscle contract as well. So what nerve, okay, you refresh on your brain, if only, oh my gosh, I would love to have that. Which nerve innervates the gastrocnemius muscle? So again, we only just kind of talked about it, but we talked about the big nerve that innervates everything down the back of the thigh and the whole lower leg. Yeah, Tanya's all over these. The sciatic nerve. The sciatic nerve. So we will often, during a basic physical exam, if we do want to check reflexes, we will often do both of these. The patellar reflex, which is telling us about the femoral nerve, and the Achilles reflex, which is telling us about the sciatic nerve. And in that way, we can kind of check off both major nerves of the whole lower limb. So that's again, this is not absolutely everything, but these are big examples of major categories. All right. Now, if you just look at the diagram, let me remove all my stuff here. Let's look at this diagram. We have a sensory neuron and a motor neuron, and this is true for both patellar and Achilles. Would you consider this monosynaptic or polysynaptic? There is no interneuron. There's no neuron in between. Monosynaptic, I'm trying to give you a clue, or many synapses, just mono. Yeah, there's just one place where the sensory neuron synapses with the motor neuron. So it's a single synapse. One sensory neuron, one motor neuron, single synapse in between. Okay? Would it be ipsilateral or contralateral? Ipsilateral or contralateral? If I tap your right knee, does your left leg twitch? Ipsilateral. Ipsilateral. Good. That's a kind of a silly way to think about it, but it's a good way to think about it. It's kind of like, oh, no, of course, that's ridiculous. If I tap a person's right knee, patellar tendon, that right thigh muscle is going to contract. I'm not going to get a response on the other side of the body. So it's ipsilateral. Like I said, the vast majority of these are ipsilateral. Let's look at the Golgi tendon reflex. The Golgi tendon reflex is similar in some ways because it's kind of some stretching involved. But the receptors are located. First of all, let's just take a look at this wiring diagram over here. That's why I asked this question first. Is it monosynaptic or polysynaptic? You see one synapse, or in the spinal cord? Lots. There's really a lot. That's because there's a Golgi tendon organ located within the patellar tendon. It also detects stretch in the patellar tendon. So it's in the tendon, detects stretch, and its afferent neuron is a sensory neuron. So it goes in through the dorsal root. Its parakaryon, its soma, is located in the dorsal root ganglion. A lot of these questions get really repetitive, so I don't cover all of them. And then in the integration center, it kind of splits, and it stimulates a nerve to contract the muscle on the opposite side, but then it stimulates a nerve to relax, or it inhibits the nerve to the muscle on the same side as the Golgi tendon organ. So contraction of a muscle can cause a reflex that actually kind of inhibits that same muscle and activates the antagonist. This is really all just about balance. Balance of force. When this muscle contracts, it actually gets a little inhibited by this Golgi tendon reflex. This very same muscle contracting, it kind of is stimulated to back off a little bit, and this one on the back of the thigh is stimulated to contract a little bit to try to balance the force. So this person is trying to raise their knee by doing flexion of the quadriceps muscle, but that will stimulate the hamstrings on the back of the leg to sort of control that movement so that your knee doesn't kick fast up in the air, if that makes sense. Basically what it's going to do is it's going to stimulate muscles on the back of the leg, on the opposite side of the joint, to tense a little bit, not a lot. It won't stop you from making the motion. It's just going to kind of tighten the joint. This is a very important activity for keeping the joints healthy and tight. Okay. The withdrawal reflex, we looked at this one already as one of our examples when we were just talking about reflexes in general. And the withdrawal reflex, the receptor is called a nociceptor. A nociceptor. What does that mean? What is the word nociceptor? The Latin word nox or noci or noci is the word for pain. Yeah, so nociceptor is a pain receptor. It's a sensory receptor that sends pain information back to the spinal cord. And it's got the afferent neuron. Notice that it is polysynaptic. 1 synapse, 2, 3, 4, multi-synapses, because again, pain, the brain needs to know about the pain, just in the event there was some kind of damage. What's interesting about these reflexes is that they're so fast that by the time your brain knows that you have gotten hurt, your hand already moved away from the painful stimulus. Your spinal cord has got it. Your spinal cord's like, I've got this. You brain, says the spinal cord, you take care of the injury. I have gotten you out of harm's way. You're welcome, right? So that's kind of how the spinal cord gets things going before the brain even knows about it. That's one of the critical survival features of these reflexes. They're hardwired in us that gets us out of danger before our big, brilliant, beautiful brain has a chance to overthink it too much. And again, is it ipsilateral or contralateral? Well, of course it's ipsilateral. I don't want to burn my right hand and have my left hand move. The hand that's burnt, or if I step on a tack with my bare foot, I need to, that one's coming up here in a second. It's called a crossed extensor. I need to be able to lift my foot out of the way of the painful stimulus. Okay? So, it asks, what are the effector muscles? Well, it really depends on where the pain is. For the one that's pictured here, the effector muscles are the biceps brachii and brachialis, your flexors of your arm. But if it was your leg or your foot, it would be different receptors. Here's what has to happen. This is a very similar response to a withdrawal reflex. So you've got the painful stimulus that uses a sensory receptor going back up to the spinal cord. But look what has to happen. You've got to relax some muscles and flex some muscles on the same side, but also relax and flex other muscles on the other side. So that when you step, here's the stimulus again right here, when you step on the stimulus, you've got to be able to withdraw the leg that was hurt while extending the leg that was not hurt so you can maintain your balance. So that's why you've got to do your extensors on the opposite side. That's why it's called a crossed extensor reflex. Okay, so this is monosynaptic or polysynaptic? Tell me, mono or poly? Just look at that wiring diagram. So poly, many polys. Yeah, poly. Ipsilateral or contralateral? That's a trick question. It's a trick question. Trick question. It's a trick question. Stop saying contra. I know I've got the word contralateral up here. That's confusing you. Is the whole reflex ipsi or contra? I know. I stunned you now. You're like, I don't know what to say. He keeps telling me it's a trick question. It's both ipsi and contra. What I mean up here, and this is misleading, I need to redo this. It's a contralateral response to withdrawal on the other side. Okay, so you have withdrawal, which is ipsilateral, extension, which is contralateral, extension on the other side. So again, down here in the diagram, you have withdrawal on the side of the injury, extension on the side opposite the injury, but the reflex involves both sides. So it's actually a bilateral reflex. It's a bilateral reflex. It's interesting, too, that you can test this in the arms as well. If we were live face-to-face in class, I would use a volunteer and show you how you can stimulate this in the arms as well. Yeah, you're welcome. This is a great example of a bilateral reflex, and you can get it in the arms, too. And you don't need it in the arms because you don't walk around on your arms. But it's a kind of a throwback to our quadruped ancestors, so it's still hardwired, but it doesn't function in our arms anymore unless you walk around on your arms and accidentally push your hand into a tack while you're walking around the house on your hands. But you can see it in quadruped animals like dogs and cats. They have to have it in their forelimbs and hind limbs too. Yep. Yeah, can I explain it one more time? Maybe. I don't know. Let's see if I can. You step on a painful stimulus and you withdraw one side and extend the other side. So it's a bilateral. You get a response on both sides. You get a response on the injured side, but to be able to withdraw from one side on one side, you have to be able to extend the leg on the other side. And all of that happens reflexively. You don't do it voluntarily. So it's bilateral, many synapses, polysynaptic. So the injury is only on the right foot, but you need the left foot to engage the extensor muscles of the thighs. That's it. That's all you need to know about it. Anything more than that is far more detailed. Yeah. I really don't want to get too much into it because I don't want you to think you need to know the details. One other one that's clinically important is Babinski's sign, or what's sometimes referred to as the plantar reflex. It is Babinski's sign is negative in adults, positive in newborns. This is what happens in newborns this is what you can do with the handle part of your reflex hammer. You kind of scrape it along the sole of the foot, and some of you are so sensitive about it, your toes are curling just at the thought of it, I'm sure. But this is a normal response. An adult, not even adults, I would say anyone over 12 months of age. I have 3 of those in my house, and they're totally not adults, but they're definitely over 12 months of age. But if you're under 12 months of age, this is what happens. And what's the opposite? Instead of curling the toes under, the toes spread out and the big toe curls back. And that's a totally normal response. It's called a positive Babinski sign, and it's totally normal in newborns. But pathological, it's an indication probably of brainstem damage in anybody older than about 12 months. Reason for that is because the reflex that controls it is in the brainstem, and it's just not wired up until you get to a certain age. A little bit about autonomic reflexes. It says list some examples. There are just a number of examples. I've got one example for sure listed here called the pupillary reflex. It's one that I talked about already. You go outside on a sunny day, or you shine a pupillary light. If you shine a pen light into a patient's eyes, the pupil should constrict. So that reflex is autonomic. It says, why is that pupillary reflex autonomic? Because it controls smooth muscle rather than skeletal muscle. Other examples of autonomic reflexes, I gave another one with your heart rate, breathing faster or slower, your lenses of your eyes adjusting for distant and close-up vision. Like, for example, if you're everybody look at your computer screen right now and look at these weird things on the computer screen, and then look up at something maybe across the room, and going from your computer screen to looking at something farther away across the room, your lenses adjust to keep focus. But they had to change shape. It takes a split second, but it had to change shape. And you were totally, again, not in control of that. And you were able to, your lenses adjusted for that difference in distance autonomically. That's an autonomic reflex. So I was trying to think of a few other examples. Has anybody come up with any other examples? Anybody got any other examples listed there? It's not like you have to have a specific list of 4 things. Hopefully, I've given you a few examples. The pupillary response is probably clinically the most important. Probably the most important one. All right. Okay. What are let's see. Oh, this is a good one. Yeah, when you walk into the sunlight, the pupillary reflex. So what are the receptors? Well, the receptors are the retina. We'll talk about these in a couple of weeks when we talk about the eye. So the photoreceptors in the retina. The afferent neuron. Well, what is the cranial nerve for vision? Cranial nerve for vision. It's called cranial nerve number 2. What is its nickname? Have you been studying these since we talked about them last week? Maybe, maybe not. Be studying these. Be studying. Yeah, the optic nerve. Yeah. Guys, cranial nerves, that's a lot to know all by itself. So definitely spend time this week memorizing those cranial nerves and what their function is. Optic nerve. Okay. The integration center is the occipital lobe of the brain. Oh, midbrain too. I forgot to mention that too. The midbrain, where the nuclei for the oculomotor nerve are located, that's those superior colliculi that I talked about last week, the visual reflex. But the occipital lobe gets the input too. The motor nerve, what controls the shape of the pupil? Well, that's cranial nerve number 3. What's cranial nerve number 3? Remember this one? This has got a long name. Oculomotor. Yeah, oculomotor. The effector muscle are called pupillary muscles. Pupillary muscles. And they specifically, we'll talk about them next week. They're called constrictor pupillae, or pupillary constrictors. Yeah. So, yeah, that's it on the reflexes. Yeah, this other stuff here is just kind of, it's interesting to me because I think it's important that as a clinician, as a future clinician, you'll probably know this. When you shine the light into one eye, that the pupil of that eye will constrict, but the other one will constrict a little bit too. It's referred to as consensual constriction on the other side that you did not shine a light in, but that's totally normal. If you shine it into one eye and the other one does not constrict, there could be something wrong with that oculomotor nerve on that side because they've lost that consensual pupillary reflex on that side. If you shine it into an eye and it does not constrict at all, it's probably damage to cranial nerve number 2. Sometimes we refer to that as paramedics call it a blown pupil. It's usually a really bad sign because it's usually not the optic nerve, but it's that integration center in the midbrain that's been damaged. If somebody has a head trauma of some kind, that's usually the problem with it. So, all right, I'm going to switch over my slides here. Yeah, I'll switch my slides over. And I think you'll see as we go through this stuff in chapter 15, it is the normal response. Good question, Wanisha. Yeah, the normal response to the pupillary response would be bilateral. Yeah, if it isn't bilateral, if you don't see some change in both pupils, there's potential problem there. It's either a problem. I laugh because I've made this mistake myself when doing a physical exam. It's either a problem with the patient's brainstem, or it's a problem with you as the person checking. And that's usually me. I've noticed that when I've noticed, I'm looking for that consensual response on the other pupil, and I'm just not, it's real subtle. And I just wasn't noticing it enough. And it's a perfectly normal, totally healthy patient. It wasn't even a patient. It was when I was in school, and we were learning how to do this. And we were doing it on each other, fellow students who are completely, totally healthy. And we're, shining lights in each other's pupils. And I was like, your other pupil isn't constricting. And it was because I was just learning how to do it, and I didn't know what to look for. So yes, it should be bilateral, but the response on the opposite side of where you shine the light can be real subtle sometimes. All right, so this chapter is all about how the central and peripheral nervous system work together, and a lot of it we've already talked about. On page 177, starting on page 177, you'll see sensory and motor pathways, these little diagrams that kind of show a typical sensory pathway. Remember that those are afferent and ascending, but the parts of that pathway that are in the peripheral nervous system are the sensory receptor and that afferent sensory nerve. I think I've got some diagrams of them over here. I'm skipping some stuff. Yeah, so take a look at this picture. I'll get back to it. Stay on page 177. But you've got a receptor out here that turns the stimulus into an action potential. And here's that sensory nerve. And that's everything out in the PNS, in the peripheral nervous system. And that right there is where it crosses into the central nervous system and crosses over into an ascending tract and heads to that post-central gyrus. And all of that is within the CNS. That's what these big boxes refer to as, are referring to. It's just what parts, we've talked about these already a little bit, but what parts of them are in the CNS and the PNS. So here's a typical motor pathway. So it begins in the pre-central gyrus, those pyramidal cells, and their axons fire action potentials through a descending motor tract. Most of them cross at the decussation of pyramids and then activate an efferent motor neuron whose cell body is in that anterior horn of gray matter that then fires an action potential. But most of this is happening out in the peripheral nervous system, out to the skeletal muscle. So I find those little block diagrams on page 177 really helpful, so that they help us see which parts of these pathways are in the central nervous system and which parts are in the peripheral nervous system, but that there's kind of this continuous action between them. So the first part talks about different kinds of receptors. A receptor is a transducer, and a transducer is anything that turns a stimulus of any kind, pressure, pain, light, vibration, taste, any kind of stimulus, and converts it into an action potential. That's what a transducer is. So a transducer is any kind of receptor that turns a stimulus into an action potential. And they're not evenly distributed all over the body, around the body. They're unequal. You probably know this, but your hands are far more sensitive than your arms. So you have a lot more receptors in your hands and a lot more space for hand sensation in your sensory cortex. I don't know if this is showing up really well. Let me kind of blot it out with a brighter color. Look at all this space in your sensory cortex of your brain dedicated just to the sensation of your hands, as opposed to about an equal amount of space, or maybe even a little less, for your whole arms and forearms. So we would say your hands are more sensitive because they actually have a lot more receptors in the skin of your hands than the skin of your arms. The term for that is punctate distribution. Punctate. It's unequal. It's punctuated rather than being smoothly distributed everywhere. This is a fancy way of saying some parts of your body are far more sensitive than others. All right? So taking a look at this diagram, you can see some parts are more represented. You can see how much more sensitive your feet are than your whole legs, for example. Adaptation can happen when, even if you continually provide a stimulus, you get reduced sensitivity, even in the presence of a continued stimulus. That's called adaptation, where we can demonstrate this really easily by saying, how long has it been since you noticed the feel of your shirt on your shoulders? Now, when I mention it, you notice it. But until I mentioned it, you probably you were paying attention to something else. And your nerves in your skin of your shoulders had adapted to that. And so they weren't really registering the stimulus anymore. Now, if it moves or shifts, they'll notice it. Here's another example of adaptation. You walk into a room. Let's say you walk into a room where, I'll use a good example rather than a nasty smelling example. I was going to talk about smell. You walk into a room where somebody's been baking cookies, and the delicious smell of baking cookies, it just overwhelms you. But after a few minutes, the smell is still there. It's just not as noticeable. But if you walk out of the room and stay gone for a few minutes and then come back in the room, you'll notice it again. That's called olfactory adaptation. Your sense of smell can adapt to it. There's different kinds of receptors based on different classifications. They can be classified by where they are in the body. This is the kind of bottom of page 178. If they're located on the outside of the body, they're called exteroreceptors, so they're going to detect changes outside the body. Okay, so this could be hot and cold from the outside of the body, but this could also be sound, light, in the form of vision. Technically, these are also chemoreceptors involved in taste and smell. Okay, so all of these are stimuli coming from outside the body. So they come in through what are called exteroreceptors. Interoreceptors, inside the body, are mostly monitoring changes within the body that you're not as aware of, but it could include pain, like, for example, the pain of, like hunger pain, or the pain of having to go to the bathroom, that sensation, that stretch pain, the pain of a heart attack, interoreceptors. Some interoreceptors detect things that you're not aware of, like your blood sugar level. Okay, so for example, the cells of your pancreas, alpha cells and beta cells, those would count as interoreceptors because they're detecting blood sugar levels. If it's too high or too low, they'll release insulin or glucagon. And they're still responding to something inside your body, even though you are not at all aware of, you, like at any one moment, unless you feel faint and shaky, you probably don't notice that your blood sugar is a little bit low. You may not notice it. Blood sodium, plasma sodium levels, all kinds of things. Proprioceptors are body position, changes in the position of the body. So these are like joint receptors, those joints, they're in the joints. So these would be examples, would be those Golgi tendon receptors, as well as those stretch receptors in the muscles called muscle spindles. Again, talked about those just a few minutes ago. But those are position receptors. So that's classified by location. We could also classify them by the actual stimulus. The type of stimulus. Mechanoreceptors are stimulated by movement. Physical change, physical movement. That's kind of how you would fill in that blank at the top of page 179. Physical change, physical movement. But that could also be vibration. You can detect vibrations in your skin. The main place you detect vibration. Sound is vibration of the air. So the sense of hearing involves mechanoreceptors that send their stimulus is vibration. Thermoreceptors are temperature. Nociceptors, we already said, pain. But what would we put in this blank? Pain is a response to cell what? Pain is a response to cellular what? It's a cellular response. It's a chemical. Pain is a chemical cellular response to cell what? Yeah, damage or injury. At the cellular chemical level, it's a way cells let your brain know that somebody's been hurt. It's a cellular response. Chemoreceptors are responsive to specific chemicals. I mentioned the cells in your pancreas that are measuring blood sugar. But exteroreceptors, examples of those would be taste and smell. The food that you taste, the smells in the air that you smell are actually detecting chemicals in the food or chemicals in the air. So taste and smell are examples of chemoreceptors. They're as classified by location, they're exteroreceptors. Classified by stimulus, they're chemoreceptors. Those blood sugar receptors, like your alpha cells in your pancreas, they are entero by location, but chemo by stimulus. So they would also be chemoreceptors, but they're enterochemoreceptors. I'm just trying to give you some examples of how all of these classifications can be applied to different kinds of receptors. Photoreceptors are found only one place in the body. They detect light And they are a very specific layer of cells of the back of your eye called the retina. More on those when we get back after spring break. And then, as I already said, proprioceptors are position receptors, and they are stimulated by movement also, but movement of joints mostly. Primarily movement of joints. Okay. All right, winding it down. Let's cover a couple. Okay. Touch receptors. These are all types of mechanoreceptors in the skin. Fine touch and texture. All right, so this would be just very light touch, being able to detect. The example that I always use with Merkle discs would be if you had some coins in your pocket and you reached into your pocket and you could feel the edge of a quarter, just feel that rough edge of a quarter, that would be fine touch or texture. Meissner's corpuscles are a little deeper in the skin, but also do fine touch, but also do a little bit of pressure and pushing too. The deep pressure, deep down below the skin, are the Pacinian corpuscles. Very, very deep pressure, usually located very deep in the dermis. These are Pacinian corpuscles. It sounds kind of weird because it's like, deep pressure. Am I getting some kind of massage? No, these are mostly pressure that you need to apply to pick up an object and keep from dropping it. So, if I let's see, just give you an example. Hey everybody, let's see, turn my camera on here. There we go. Hopefully that's coming through. There we go. Hi. So I got my coffee mug here, as you know. So when I go to pick up, make sure I don't spill it, but here's that's my daughter, like 11 years ago. I forgot that this is my daddy mug. There's me years ago without a beard. So here I go. I'm really going to do this right because this is my most precious daddy mug that I own, right? But watch this right here up close. When I grab the mug, I don't want my hands to slip. So if I use too light of a pressure, my hands will slip. If I use too much pressure, I may break the mug. But those Pacinian corpuscles tell my brain, am I using enough pressure to lift the object without dropping it and letting it slip, but also not to break it or crush it, right? And that's how the Pacinian corpuscles actually communicate back to my brain as to, am I using the appropriate amount of pressure on the object? And that's kind of what's meant by deep pressure. I hope that example makes sense. Makes sense to me. So let's get back to these receptors. The hair root plexus, movement of hair. This is how you sometimes can feel if the air in the room is moving or whatever. That's what those do. Those sensory pathways, again, many of these we've already talked about, but there are certain specific ones that we want you to identify. So a general sensory pathway, we've got a receptor out here that turns the stimulus into an action potential. We got our sensory neuron that's in the peripheral nervous system. It's called a first order neuron. Okay, that's that afferent. It's unipolar, and it brings it in through the posterior or dorsal root. Its cell body is in the ganglion. And then it synapses right there in the spinal cord with another multipolar neuron. This one's the second order neuron, and it's going to go from the spinal cord up, usually the anterior spinothalamic tract, or the posterior. It could go up through a number of different ones. And it's going to go up, and it's going to synapse in the thalamus. Okay, so that second neuron, called the second order neuron, is part of what's called the spinothalamic tract, because it's going to go from spinal cord to thalamus, there. Then we need a third order neuron to go from the thalamus to, again, the appropriate part of that post-central gyrus. That's the thalamus's job, is to make sure that this incoming stimulus, which looks like it's hitting right about your pinky finger right there. So we've got a stimulus right here. You smashed your pinky finger in the door, and that stimulus needs to go to the appropriate part so your brain knows to pay attention to your pinky finger and look at it and see if it's okay, and if it's not okay, what do I need to do about it? Okay, so that's the general pattern for general somatic sensory pathways. Here are a few specific examples. Again, notice the names: spinothalamic, spinothalamic. If we show you on the exam a spinothalamic pathway and ask you if it's sensory or motor, we want you to be able to say, oh, spinothalamic. They're named for the start and end. So the start is spinal cord, end is thalamus. It's going spino to thalamic. It's going from, it's ascending, it's sensory. Okay? So if we give you a name like that, we want you to be able to put those pieces together. Now, the anterior spinothalamic pathway is our pathway for what we call crude touch. That reminds me of that movie, The Croods. Different kind of crude. Sorry. Different kind of crude. Crude touch and pressure. This is all the way at the bottom of page 181. Very bottom. Crude touch, not very bottom, but crude touch and pressure. The lateral pathway is pain and temperature. Pain and temperature information. So this is actually how the brain and spinal cord keep the impulses sorted out. Kind of keep the impulses completely sorted out and make sure they're going to the right place. Okay? The anterior is going to be crude touch and pressure. The lateral is pain and temperature. Okay? And I've tried to say that as simple as I can, but it's in bold at the bottom of 181. Please memorize them. You will very likely see a question that says, if a patient severs only the anterior part of their spinal cord, which of the following senses will they lose? Okay, did everybody get that? I know it's late on Friday. Test question alert, test question alert. Everybody wake up, test question alert. Splash some water on your face. Wake up. Are you there? Pretty good. Okay. If they only sever the anterior spinothalamic pathway, what sensation have they lost? And again, it's spinothalamic, so it's sensory, it's ascending, but anterior is crude touch, pressure. Again, crude touch is not fine touch. Crude touch is just kind of like the rough sensation of touch. Okay? Or pressure. So again, they might be going to pick up a mug and they keep dropping it. It slips. They don't have any way of determining if it's the right amount of pressure. So make sure you memorize those two anterior and lateral pathways. Okay? The posterior pathway, the posterior column pathway is the one. Where is it? Where is it? Oh, it's over here. It's all the way over here on 183. We're not going to bother drawing all of them. The posterior column pathway is specifically for the pathway for what's called discriminative touch. In the textbook, it's called fine touch. But discriminative touch is a good name for it because it allows you to discriminate between different sensations. So, let me use that example of coins in your pocket again. You reach in, and if you can feel the difference between a quarter and a penny, that's discriminative touch. You know, again, if you can feel the ridges on the edge of the quarter, that's discriminative touch or fine touch. Okay? So if you had damage to the posterior column pathway, if you had damage to that pathway, then you would not be able to tell the difference between a quarter and a penny. You could feel them, but you wouldn't actually be able to feel the difference, as weird as that sounds. Now notice another difference. This pathway, the second order neuron, crosses in the medulla oblongata. Okay, so make a note of that. In the posterior column pathway, the second order neuron synapses not in the spinal cord, it synapses in the medulla. Okay, it's the first order neuron that goes all the way up the spinal cord until it gets to the medulla and then synapses there. Okay, now, by the way, here's a big note. Big note. For sensory pathways, again, is everybody paying attention? I just want to make sure you're getting this. I know we're tired, but these are big concepts that I'm pretty sure are going to show up on the test. Okay, so again, just kind of do a quick brain refresh. I know, me too. I'm wearing out. Here's the big thing. This could go two different ways, two different kinds of questions. This is not completely true, but it is true for the pathways we want you to know. For all the sensory pathways we want you to know, for all of them, second order neurons end at the thalamus. They don't all begin in the same place. This posterior, the second order, begins in the medulla, but they all end in the thalamus. All of them, from page 181 all the way over through page 183. They all end in the thalamus, okay? Look. For all the pathways that we want you to know, the third order neuron begins in the thalamus. And ends in the post-central gyrus, or the primary somatosensory cortex. The third order neuron begins in the thalamus and ends in the posterior, or the post-central gyrus, primary somatosensory cortex. Okay? For all of them that we want you to know. The only difference between the ones on page 181, the anterior and lateral, between those two, I'll go back to them. Between both of those, anterior and lateral, that's why I put them both on the same slide. The only difference between those two and the posterior column pathway is where that first order neuron ends. Okay? In both of these, the anterior and lateral, the first order neuron ends in the spinal cord. Ends in the spinal cord. It synapses with that second order neuron as soon as it comes in, immediately. In the posterior column, those posterior columns actually are the axons of the first order neurons. They go all the way up to the medulla. So I want to try to highlight some of the similarities and differences. All right, let's finish with motor. Oh, the spinocerebellar pathway. Yeah, one real quick note on this one, because there's just one little fill in the blank. Proprioception, top of page 184. Proprioception, spinocerebellar pathway. It's going from the spinal cord to the cerebellum, and it is basically sending really subtle information from, check it out, Golgi tendon organs, right down here, muscle spindles, joint capsule receptors, all those things we've kind of talked about before. They're mechanoreceptors that are stimulated with movement. And then finish up with the motor pathways, which we've kind of already talked a little bit about. There are two major motor pathways, the direct somatic motor pathway and the pyramidal pathway. The somatic motor pathway called the direct pathway is corticospinal pathway. No, not also known as. I don't know why. I made a mistake maybe in my notes here. Let's pretend that's not there for now. Yeah. No, it's fine. I'll clear it out. Sad. My brain is so fried right now, guys. So here's another big difference. Let's make a point of two big differences. We go backwards. Check it out. Sensory. 1, 2, 3. First order neuron, second order neuron, third order neuron. On the way up, you got to have 3 neurons because you got to make a stop over in the thalamus, right? Motor. Let's contrast that with motor pathways. The descending motor pathways do not go through the thalamus. We have 1, 2, an upper motor neuron and a lower motor neuron. The lower motor neuron always, well, okay, not always true, but for the pathways we want you to know, the lower motor neuron always has its cell body. It always starts in the anterior gray horn of the spinal cord. There it is, right down there. Okay? No matter what pathway the upper motor neuron takes to get there, they take a few different pathways. The lower motor neuron is always going to start at the same place. Okay? So, the cell bodies of the upper motor neurons, right up here. Primary motor cortex of the precentral gyrus. Okay? They descend through the cerebral peduncle of the what we call the midbrain last week. Most of them, about 80% of them, cross at the decussation of pyramids in the medulla oblongata and continue down the lateral. Now look at the name of it. Check it out. Cortex to spinal cord. Cortico, there it is again. Cortico-spinal tract. That's telling us a lot. It's going from cortex, brain, to the spinal cord. That's how we know from its name that it's descending, which means motor, which means efferent. That's how we know from the name. It's descending motor pathway. Okay? That's it. We'll look at these questions when we come back. I've got a couple of pages of some sample questions, but I want you guys to study this, and you'll have a quiz over it, maybe I think the week after spring break. So you deserve a break. So do I. I'm going to take one. But yeah. We covered everything that we needed to cover. We're fully caught up. We're going to